Hello, welcome to our second MedPed Star Talk for the year. Austin Wesovich will be speaking today. Austin grew up in San Antonio, Texas, and did his undergraduate medical studies at WashU in St. Louis. Austin has had a long-standing interest in research and global health and medical education, and his curiosity into relationships influenced his decision to talk about physicians and relationships for this Star Talk. His two mentors for the talk are Dr. Gina Mooneyham, who's a child psychiatrist, and Dr. Susan Hazlitt, who is a psychologist. In the spirit of connecting with our graduates, Austin identified Dr. Steve Pappas as a graduate he would like to highlight. Steve graduated from the categorical medicine residency this past June and now serves veterans at the hospice at the VA in Chicago, where he's currently on the teaching service and is unable to join us live. Steve inspired Austin when he first met him with his intellect and humility. Prior to medicine, Steve studied music and served in the Marine Corps, including being deployed to Afghanistan. His principles guide his decisions and interactions. During residency together, Austin got to see how his relationships became first and foremost as he faced new challenges. So now I will hand it over to Austin to start his Star Talk.
Hi, everyone. Thanks for joining today on Zoom. The topic today is a little bit non-traditional. So I picked a non-traditional opening slide, but basically, if you know me, you know I'm very invested in relationships, and I also love data, as Jane just talked about with research. So I thought I would talk about how relationships and data meet through this talk on physicians and relationships. So I have 4 objectives for my talk today. The first is to establish the importance of relationships in kind of from a developmental perspective. And the second is to address barriers to relationships inherent to medical training. The third is to look at existing data on medical marriages. And finally, it's to maybe empower you with some skills that can contribute to successful relationships. So throughout this talk, I have a series of questions. And since we're in a Zoom format as opposed to in a lecture hall, I invite you maybe to think about these questions introspectively if you're able to. I know many of you are out in different work settings, but if you can kind of pause just for a moment to think about each question as it's posed. If you're sitting next to someone and you want to talk about it, please feel free. So the first question is, why should we even value relationships? So I'm going to go through a couple different psychological principles that speak to the importance of valuing relationships that I think make relationships inherent to be developing into a healthy human being. So the first is attachment theory. It was developed by John Bowlby and researched by Mary Ainsworth. And it really centers on accessibility and responsiveness. So, and we'll get back to that a little bit more. So Mary Ainsworth did a study where she looked at 12-month-old infants and saw how they interacted with their moms and their strangers coming in and out of the room. And she was able to kind of classify these infants into 4 different categories, which we're about to go through. And these 4 categories, when they classified the same infants as adults, corresponded 68 to 75% of the time. So the attachment that you the attachment patterns that you glean in the first year of life can really have lasting impact through the rest of your life. So the first category is secure autonomous. This is the ideal and what a majority of, at least of people or Americans are in. And it basically means that you're free to connect, explore, and reflect. The second is avoidant dismissing. Think of this as having emotional control. So it's about suppressing automatic emotional expression, promoting distance, control, and self-reliance. On the flip side, the ambivalent preoccupied one is the opposite. It's really emotional underregulation. So someone who is clingy, angry, fearful, or passive. And finally, the 4th category, disorganized or unresolved, results from scars of trauma and loss. It's about controlling and role reversal. So to go back to these 2 themes of accessibility and responsiveness and how it might relate to medicine and how you might think about attachment, maybe think about, for accessibility, can I get to them? Are you at work? Are you in the surgery or in the OR? Are you taking care of a patient? How accessible are you? And second, think about responsiveness. Will this person respond to me? Are they too burned out by work? Are they difficult to talk about? They find it difficult to talk about mundane things after a long day at work? The second theory that we're going to talk about are Erikson's stages of psychosocial development. This was developed by a couple, Eric and Joan Erikson. It goes through 8 different stages of psychosocial conflicts where there's 2 contradictory emotional forces. Think about them as syntonic and dystonic dispositions that you can have. Now, because I'm med peds, this goes from infant all the way to geriatric population, but we're going to focus in on 2 different ones. And basically, when you're going through these different stages, so I'm focusing on an adolescence and young adulthood, You are faced with these contradictory emotional forces, and you can either resolve the crisis and achieve competence, or you might not be able to resolve it and then have some less healthy coping skills. So we're focusing on adolescence because that's the time when you're pre-med, and then into the med school and residency years as well. So for adolescents, the conflict is between identity and role confusion. So I want you to think about these questions. Think back to when you were in high school, college age, and think about, who was I? What did I think I could be? When did I form my occupational identity? When did I form my sexual identity? And the ubiquitous question, did I identify as pre-med? And in the time that I took studying for the MCAT, trying to boost my science GPA, doing research, did I make time for friendships, for relationships? Moving into young adulthood, the role conflict is between intimacy and isolation. So now think about med school, residency, going into fellowship. Where did I find companionship and intimacy during these years? How have I sacrificed or compromised for relationships? Have I had a painful rejection in my life? Do I have a fear of rejection? And what about this term distantiation that Erickson defines as isolation to avoid or destroy harmful people or negative forces? Can I identify with that? Finally, how did medical school and residency help or hurt my ability to express love and intimacy? Now, I understand that these are questions that we don't typically think about in noon conference, but as I go through the talk, I'm going to emphasize the importance of doing this. So as we go from these importance of attachment theory and psychosocial development, we move into a social expectation that we basically eventually will stop studying, finish training, and maybe settle down. Now, the talk in general is about relationships. We're going to focus more and more in on dyadic relationships. So when I think about dyads or partnerships, it's who you might want to spend your life with. As we talked about in the young adulthood, that's part of intimacy versus isolation, the development for many people. And in relationships with dyads, we can think about going through three phases: dependence, independence, and interdependence. However, the dyads that are exemplified to us in the medical field may teach us part of these things, but not all of them in the ways that a romantic or a platonic friendship might. For instance, for the doctor-patient relationship, medication adherence might be an aspect that teaches us about dependence in a relationship, a dyad. Patient autonomy may teach us about independence. But when we're in medical school, we learn about transference and countertransference, how we're really not supposed to move into this interdependent phase. I'll give another example to bring home the point. So in the teacher-student relationship, which is another dyad that we're very familiar with in medicine, we might rely on dependence with medical hierarchy. We're a new clerkship student just learning how to be on the wards. We might then move to independence as we do self-directed learning and guide our educational experience. But in the effort of professionalism, there are certain boundaries that we draw before moving into an interdependent dyadic relationship in the teacher-student genre. So if we're going to try to learn more about how we form this attachment and develop psychosocially, we might want to meet a significant other. In order to better understand how people met their significant other, I polled doctors across the country, all ages, all specialty types, and in all different stages of relationship: dating, engaged, married, and of all different sexualities. And I've provided some quotes here about how they met their significant others. Now, the quotes I've divided into one doctor and two doctor couples and done a little bit of color coding to help guide you. So as you can see in the one doctor couples, some people, their parents were friends, they met in college marching band, on Tinder, doing music for mass, or even at a college party doing fake Skittle shots. In the two doctor couples, maybe they met on labor and delivery triage, or in residency, where one was a GI fellow and she had a lot of GI consults. One doctor couples may have met in college, dated, and met her again at church. They lived a few blocks from each other and they met at a wedding. For two doctor couples at a medical ethics conference in college, but they were both in the BSMD program, or in med school and became study buddies. And this pattern continues. One doctor couples, kickball tournament, undergrad mixer, two doctor couples, med school, residency, residency. And it goes on and really follows a lot of these same patterns. Anatomy partners in the hospital, but eventually through Tinder. I like the Kaplan MCAT prep class. So kind of moving through this, I noticed these patterns of there are different ways of meeting people. And if you wait for medical school residency, you may very well meet them in your workplace because that's where you spend most of your waking and sometimes even sleeping hours. Now, one thing that I have to go through is the importance of dating apps in today's culture. So this is a quote that I wanted to highlight for everyone. This was one of the responses from a physician. Tinder, it was actually my first and only date on Tinder. I tell him that I should have looked around more. His Tinder profile said, if Tinder is a meat market, I'm looking for a nice salad. And he didn't say he was a physician. So I initially thought he was a security guard or something because he was working night shifts at the time. So as you can see, dating apps through all the red highlight bolded words throughout the quotes are certainly part of the profile and how we might meet others in today's world. As a sort of disclosure slide, this is me with my wife the day that we met. So I am not an expert on dating apps. I met my wife my first year of med school in a wedding in Los Angeles where she was a bridesmaid and I was a groomsman. And yesterday we just celebrated our 2-year wedding anniversary. So I'm certainly not an expert on long-term relationships, but I'm learning as I go. So that is where I'm coming from. And when the two of us got married 2 years ago, we had a medical marriage. And I want to make sure that we've defined this term the same way across the board. So medical marriage is defined as at least one partner is a physician. And I'm going to move the talk more and more towards this topic of medical marriages now. So maybe when you're in medical school or residency, you thought about whether you should marry a doctor or not. Some of you have, some of you haven't. I'm going to go through one study here that talks about 1 and 2 physician marriages. Now, I want to start off with a caveat that unfortunately, all the medical marriage literature that I'm about to go through is all on pretty much heterosexual marriages. We don't have enough literature right now on other types of marriages or partnerships that exist. But I will say that in the general psychology literature, same-sex marriages follow the same patterns in what leads them to success or failure as heterosexual marriages. So we might be able to extrapolate that at least for today's talk while we wait for more data on medical marriages. So I've symbolized these couples in 3 different ways at the top, using either 2 physician where they both have stethoscopes or the 1 physician marriages side by side. This was a study in 1999 that surveyed 2,200 physicians who graduated from either Case Western or University of Cincinnati from 1980 to 1990. There was about a 60% response rate. So just overall in the numbers, about 1/3 of the female doctors were married to another doctor, and about half of them were married to a non-doctor, and the remainder were either divorced or unmarried. On the flip side, for male doctors, only about 1/5 of them were married to another doctor, 70% to non-doctors, and the remainder were either divorced or unmarried. Now, if you're a doctor and you marry another doctor, most likely your spouse works more hours than they would if they were a non-doctor. And that's probably not surprising to people. What you might not expect is that you may take a lower personal income if married to another doctor. However, your spouse will make more, most likely, and thus your total income will be higher. When talking about kids, male doctors married to non-doctors, particularly those who did not work outside the home, had the most kids in the study. Now, who takes care of the kids? If you're in a 2-doctor couple, you're going to take a greater role in the childcare than likely you would have in a 1-doctor marriage. Finally, how much are you going to work? If you're a male doctor, whether you're married to another doctor or a non-doctor, you work about the same. But if you're a female doctor, you choose to work less in a 2-physician marriage, at least in this study, where if you were in a 1-physician marriage, you might feel fewer professional limitations for family responsibilities. Now, what about the risks for doctors in relationships? The risks to medical marriages I'm going to divide into 2 different categories, stability and satisfaction. You can think about this as quantity and quality, where the left is talking about divorce and the right is talking about how happy you are. So the risks to stability include more nights on call per week, spending fewer minutes awake together, not having any kids, marrying before you graduated from medical school, less emotionally close to your parents, or having a higher anger. And as you can see, some of these are things that you can potentially affect. And anytime we talk about risks to something, we want to see if they're modifiable risks, and a number of them are. Choosing what specialty you go into, whether you have kids. Clearly, everyone listening to the talk has already finished medical school, so if you have waited this long, and then how your relationship with your parents and how you manage your own anger. For risk to satisfaction, some of these are also modifiable. So again, more nights on call per week, staying in unhappy marriages for financial needs or social status, role conflict, which you can think about as the role that you take in as a parent, as a spouse, and as a physician. Are those roles in conflict, or is there an understanding across the family about how you integrate with all those roles? It's kind of like the work-life integration or balance concept that we talk about. Long training process, high educational debt, maybe less modifiable risk factors. Delayed gratification mindset, depends, I think, on your personality. And then finally, prioritizing work over personal responsibilities is a risk to marital satisfaction. So I talked a little bit about choosing what type of field you go into. Everyone listening today, for the most part, is in internal medicine, pediatrics, or my favorite, med peds. So this is a graph that looks at specialties beyond those. And you can think about internal medicine and pediatrics, which I've highlighted on the graph with green and blue, as sort of the reference group, if you will. So psychiatry was the red, had a 3 times higher rate of divorce. So we're looking at cumulative incidence of divorce over time in this graph. And surgery in purple, or sorry, in yellow, had 2 times the rate as internal medicine, whereas pediatrics and pathology were about the same as internal medicine. However, another study showed that choice of specialty did not relate at all to marital satisfaction. So while you might have a higher incidence of divorce, the specialty isn't a deciding factor of how satisfied you are. So a little bit more on divorce, and then we'll move into more positive topics. So are you more likely to get divorced because you're a doctor? People have speculated on this and talked about it. So I looked into the literature. A lot of the literature is from many decades ago. And in general, in looking at the progression of the studies, besides one initial study in 1972, the studies showed that in general, doctors were in more stable marriages, or that they were less likely to have divorce. So, and also this 1972 study that showed that 47% of doctors versus 32% of controls were either in a bad marriage or had gotten divorced. This data was reanalyzed in 1989 by a different paper and showed no significant difference between these two groups. All of the other studies were on divorce filings, divorce rates, and they all showed that doctors were about the same as their other educational group or lower than general population. I will say that with the final study on the bottom right, this is the table from that study looking at male and female divorce rates for physicians, employed population, and other professional specialties. Some things to point out: from 1970 to 1980, across the board, the divorce rates went up. And we know that divorce is becoming more common over time. Also, male physicians in general had lower rates than female physicians for divorce. Finally, in 1970, female physicians were about equal to the employed population and higher than other professional specialties, but they were lower by 1980. Finally, let's just compare divorce rates within the hospital and some other sort of professional spheres that might be of interest. So doctors are on the left in yellow for either currently divorced or ever divorced. And as you can see, and this is a study from 2014, so much more recent, that doctors had the lowest rates, or one amongst the lowest rates of currently or ever divorced, compared to the highest being for nurses or for non-healthcare professionals. And of note, I also want to point out that lawyers are here in the dark blue, and that they also had higher rates, which we'll talk about a little bit later. So we've got through all of the risks that you have towards stability, satisfaction. What are some things that might help you succeed in relationships? So several studies have pointed out different factors that might improve medical marriages for stability and satisfaction. So for stability, the first two on the left, higher education and income and marrying later than average, this was comparing medical marriages to marriages as a whole. But they did note in this study that lawyers also have higher education income and marry later than average, and they don't see as quite the benefit as medical marriages. So there's other factors as well. The third factor, death of a parent before graduating medical school, I think we can speculate on if that means their partner provided support or what it might mean, but obviously not a modifiable risk factor. Improving satisfaction. So I'm going to group these kind of into thirds as we go through. So mutual support in marriage, supportive spouse, recognizing each family member's role, decreased role conflict. These are all about everyone understanding the roles within the family that everyone has agreed upon to be a part of. The middle section, sharing values with your partner, receiving emotional support, parental satisfaction, acknowledging benefit of physician to the relationship, giving emotional support. And this is about the communication aspect, which we'll talk more about later. And finally, just minutes awake with your physician partner per day, hours spent alone, protecting creating time. You got to make time for your significant other. And I know that that is difficult amongst the demands in medicine. This is a very interesting study from 2013 out of Mayo that that surveyed spouses of non-physician spouses of physicians. So if you want to know what your non-physician spouse thinks, pay attention to this slide. So in general, I'm going to go through panel by panel in the table. So for panel A, if you look at it, it's mean time spent awake with your spouse or partner per day. And as you can see, there's a dose response. As you go more time with your partner, your non-physician spouse is more and more satisfied with the marriage. And this is a range from fewer than 20 minutes per day to up to 2+ hours per day. And what a difference that can make. For panel B, this is hours worked by the physician. So this is the hours you choose to work. The more hours you work, the less satisfied your partner is. And again, that probably relates to panel A and how much time you have available to spend. Panel C is about nights on call. So choosing if you're going to be a nocturnist for that extra pay or ICU or what you want to do or working overnight, what toll might that take on your relationships? So the number of nights on call decreased, or the satisfaction decreased as you went from 0 to 3 and bumped up a little bit at 4 or more. Again, maybe getting used to some sort of norm. But really thinking about how the choices that we make about our call schedules can also have an impact on our relationships. And finally, for panel D, this is the non-physician spouse's working hours. And in general, when they're responding themselves about their satisfaction, if they're not working outside the home or they're working full time, they express the highest satisfaction. So a topic that's been very, very much discussed lately is on wellness, burnout, resilience. And I would argue through my talk here that there are important aspects to take away from this on how what you do and how you invest in relationships can greatly affect your wellness and burnout. And relating it back to the first slides about attachment theory and psychosocial development, having relationships, fulfilling relationships are hugely important to your health as a human being and part of your development. So the first example is again from the group out of Mayo in 2017, and this is their figure. We talk a lot about the right side of this figure, how burnout can affect the quality of care we provide, how much the patients are satisfied, how productive you are, physician turnover. Those are common things that we know about with burnout. We also even sometimes talk about depression and suicide with burnout. But what about the top right, the top left, broken relationships? How might burnout affect your relationships at home? On the flip side, you can think about this in terms of the relationship between mental well-being and empathy. So if we're trying to build resilience, how can you show empathy? Again, this can be thinking about in terms of patients and coworkers, but also in terms of family members at home and how that might positive feedback loop improve mental well-being. So I'm going to offer one or two different strategies on how you might take this home with you. So the first is looking at John Gottman. John Gottman is a psychologist, a marriage family therapist out of University of Washington who's done a number of research on relationships and found that this concept was one of the best predictors of who would be divorced or not at 5 years out. So this is a concept of bids for emotional connection. And you can think about it in this way. Say you're sitting on your laptop watching Netflix after a long day at work, and your roommate or your friend or your significant other comes through the door and says, "Hey, I gave a presentation today. I was so nervous." Now you have a choice. You could choose to look up from your Netflix, or you even pause it, look towards them and say, "Oh, really? Tell me about it. How did it go?" You could choose to kind of keep watching that show and without looking up to say, okay. Or you could pause, glare at them and say, "Whatever, can't you see I'm busy and I'm tired and I don't want to hear about it?" John Gottman labels these as turning towards, turning away, and turning against an emotional bid. The choices that we make, even with these small things, whether they're about the weather outside looks nice, or did you see that Duke basketball score from last night? How you respond to those are hugely important for the success of a relationship and in building empathy and connection, which is so vital to attachment theory and us feeling revitalized. Another way of looking this is through the lens of this active, passive, and constructive, destructive responses. So another sort of example, your roommate or your friend or your significant other comes home and says that they're being considered for promotion. You can respond in the top left, which is the ideal. "That's wonderful. I'm so happy for you. You'd be excellent." Active, constructive. Active, destructive, which is more about turning against. "If you get the promotion, you're going to have to be at work all week and on Saturday mornings too." It's being negative about their bid for emotional connection. And then the bottom two, passive constructive and passive destructive. That's nice that you're being considered for the promotion. It's sort of a wishy-washy response, like that turning away. A promotion, huh? Well, hurry up and get changed so we can get some dinner. I'm starving. And we talk a little bit about that in our patient relationships. This is the one that's a little bit different from Gottman's bids, but it's turning the direction of the conversation back towards you as opposed to the person with their emotional bid. So thinking about all of these things, the importance of attachment, the importance of connection, how medical marriages or medical relationships and medicine as a whole makes it difficult. What are some things that we might be able to think about in the future if you were to decide to research this or look more into it? As you notice from the studies, much of the studies are from several decades ago with a huge gap. There's increased talk more and more now about burnout and wellness. And time is right now for more data. As we also know, COVID has totally changed things. I'm sitting alone with 2 lamps and a light and not in front of any of you because of COVID. People are feeling more isolated. I don't have kids yet, but when people have kids, especially school age, they're trying to teach them and manage them while they're working from home. And there's an increased burden of childcare and stress on relationships with COVID. Hugely important to look at how that has affected relationships. And finally, night call has changed, and maybe I could change outcomes, and we just need more data. So I leave you with these takeaways from my talk today. First, relationships are central to our development. Second, as you all know, medicine is very hard. It can make relationships difficult, but time together is key. And what are choices that you can make to create more time? And finally, regardless of the amount of time you have, how do you make the most of your time with others by turning towards their emotional bids? I want to end my talk with a few notes of gratitude. First, at my time at WashU, I connected with Lisa Moscoso, who's a MD PhD Peds hospitalist and Dean of Student Affairs, and her husband, Tom Wagner, through my church community. They were the first ones who introduced me to the concept of medical marriages in the literature out there, and I thank them. Second, I want to thank my talk mentors, Gina Mooneyham and Susan Hazlett, who are both here at Duke in psychiatry and psychology. And finally, the person who's taught me the most real-world experience about all this, my wife, Megan. And now I want to open it up for any questions or comments. Thank you for your time.
Thank you, Austin, for highlighting some great communication goals that we can think about as we interact with others, particularly in this kind of stressful time period. Dr. Cohen has a question in the chat, or comment more. Something that we should be commenting that we should be talking about this topic more often. Thanks, Dr. Cohen.
I have a question, please.
Hi, Dr. G.
Hey, I love this. I did my JAR talk back in 1987 on being married and being a doctor. And the data back then, and I would say medicine was starting to change. You know, the best, I think Harvey Cohen would agree with me, the best change in medicine over the 30 plus years I've been here in the 40, I think Harvey's been here about 80 or 90. The best change is not the 80-hour work week, but the fact that women are more than half of our profession. And I would speculate, I don't have any way of knowing, that we're a better, more balanced group as a result. And I wanted to ask you, Austin, because you're a very sensitive, thoughtful guy, as you go in your travels during your training and people confide in you or share with you personal issues, how much of this topic is what you folks discuss?
When you say confide, are you talking about patients or like my coworkers and friends?
No, I don't care about patients, you know that. I was talking about, to follow up on Harvey's point, how much are we as a house staff talking to each other about these crucial issues that you covered today?
I would say that I tend to take risks in conversation, and I tend to try to bring the conversation towards deeper topics and kind of just see if people are interested. I did find that when I just shared this general topic of this talk with people and asked them kind of how they met their significant other, people had general excitement and interest, which I thought was encouraging. And that's kind of the key, right? Is if in order to invite conversation or connection, someone has to take that leap and just sort of talk about it. So I think sometimes nights or the workroom or things like that can be a place where that can occur. And I'm hopeful that that's something I really appreciate, I think, about internal medicine and pediatrics is, in general, the cultures are open to inquisition, connection, talking about some emotions and stuff. I've certainly enjoyed connecting with my psychiatry colleagues about some of this stuff as well. But I think that it's growing. I don't know what the culture was like 20, 30 years ago, but from what I have heard, it sounds like things are changing in a positive direction.
Thank you.
Thanks. Going through the questions in the chat. So from Kristen, how can we translate some of these ideas to patient-physician interactions? Thanks so much for asking that. I think this is really important. These are general communication skills that can help you connect with people regardless. So if you're trying to build relationship and rapport with your patients, you absolutely can turn towards their emotional bids. If they say, hey, my back's hurting, but you want to talk about their hypertension, don't shrug off that they talk about their back. Recognize that, hey, I'm sorry your back hurts. Tell me a little bit more about that. And obviously we're pressed for time and we have to kind of balance those things. But I think absolutely these ideas translate into patient-physician interactions.
So the Gottman schema is really almost exactly the plan for empathic communication.
Yeah.
I mean, it's the same thing with some different words. So you're exactly right. This is totally applicable to patient-physician relationships.
From Sue Woods, former Duke program director, what are some positive you learned about in your research with a medical marriage? I believe there are many. I mean, one of the positives is that they're more stable. I mean, I think divorce was very scary for me when I was thinking about personally about deciding whether I wanted to get married and what that would mean. And it's nice to see that when people wait longer and are educated and are more financially stable and they have thought about their decisions, that ultimately their divorce rates are lower. I think also there's a lot of potential for kind of impact. And this is more, I think, less Dr. Woods in terms of the research and more just kind of personal examples of meeting different doctors and the value they place in their relationships. But several of the first quotes are from people well in their attending lives or even retired and the examples that they've set in medical marriages. But I agree that there are many positives. I think I focused more on the risks just to kind of, I don't know, that's typically how we talk about talks of sort of just what's the problem and how do we address it. But I agree with you that there are a lot of positives. From Dr. Suchita Sata, thanks for your talk. I particularly found the discussion about turning towards, okay, I think that was, well, thank you, Dr. Sata, I appreciate it. And then from Troy Wojtek, I'm curious if there's more recent data that shows these trends have stayed true. And the best group that I found is Shanafelt group out of Mayo. Almost all the recent data is from them. And I didn't find a lot of recent data besides them, which is why I had that future direction slide. If there are people who want to research these things or look into them, I do think that it's time for an update, especially kind of in what I talked about earlier about the types of marriages or relationships that exist beyond heterosexual marriages. So I agree that there is time for more updates on this.
Hey, Austin. This is a great talk. I loved it. I say this as someone who is not married to another physician, but it seems like to me one of the greatest things that's helped when it comes to two physician medical marriages is the couples match for people who meet their spouse before medical school is done. I was wondering if in your research you ran across any opinions or thoughts maybe before when they were deciding to institute the couples match, and any thoughts about how it affected them or helped them afterward?
I really like that question. I did not find anything specific about the couples match. I think when I was talking earlier about kind of have you kind of in the attachment theory aspect, like how much sacrifice have you made for your spouse? Like when have you chosen to make sacrifice? I thought a lot about the couples match or ways in which people have said, hey, I'm gonna take what I really want professionally and put it down a notch because this relationship's the number one. And we've all watched different people approach their relationships differently in this regard. So I think that that's more of like an application. I didn't find research on this, but to be honest, I think I read most of the articles about medical. I don't know how many there really are, but I think I read a lot of them, and I don't remember seeing that. But I think that's a great question, Danielle. Thanks.
Does anyone actually know when that first started? Like what year that was instituted?
Great
certainly evolved.
Yeah.
Because there used to be separate matches, and there's still, to an extent, there's a couple programs with early matches. There's a San Francisco match, and then that was separate from NRMP match. So the couples matches certainly evolved over years and decades.
Yeah, this is Amy. I can say from personal experience, at least 20 years, but I'm not sure how long, but I'm going to look after this. But anecdotally, at least, and Jane and Sue and Betty can probably help with this. The number of applicants that we get in couples matches over the past period of time that I've been looking at ERS has gone up each year. And I suspect the NRMP has that data. That would be interesting to see too.
So Austin, one of the other complications of two physician marriages is in the after residency in the job seeking market. And it's complicated for a number of reasons. I'm wondering, did you see any data on sort of that issue and how that plays out?
The only study I was able to find about two physician marriages was the one that I presented about Cleveland, kind of that really focused in on subdividing that population. A majority of the studies, because they're from 1960, 70, 80, are mostly male physicians with a non-physician spouse, just because of the demographics of those decades. But I mean, kind of speaking on that a little bit, I would say that the stat about that both are choosing to work, or at least, sorry, the female is choosing to work fewer hours and both are choosing to take a lower pay. So I think also sort of says some of that compromise that is existing in what sort of job you're accepting at what pay in order to achieve both of you having jobs in the same area, which I think is maybe what you're touching at.
Yeah, yeah. Especially in the academic environment, that's been a very complicated issue of a place that doesn't necessarily have the right jobs for both partners. Makes it very complicated.
Oh, do any of those more senior faculty have suggestions on how they can recruit two physician spouses? Because I don't recruit anyone.
It's a real problem. We try to do things like contact other people. It's much easier for places that are in a place where there are multiple academic programs. You know, if you're in Boston, there's a lot of schools around. We're actually relatively fortunate here because at least it's a relatively rural area, but at least there's a few schools relatively close. So that, you know, that you can shop around that way and try to find matches. But it's tough. It's a problem.
And Dr. Zata, I really appreciate your point about kind of the added burden barriers, particularly for female physicians, which is kind of that bottom part of that slide I talked about, where they do tend to work fewer hours than they would be if in a one physician marriage. And just that's certainly some of the social expectations or how we approach things exist within medical marriages, at least in this 1990 study.
Austin, maybe I can interject. This is Cami, that at least as far, not with respect to recruitment, but with respect to supporting physicians in general, and especially physician spouses, the pediatric department has done a survey to get input from all of their faculty on barriers and challenges during COVID and how to enhance telehealth visits, evening visits, Saturday visits, other things that might help couples who are also dealing with young children or children in school. And then just on the couples match, I know when we looked at this about 10 years ago, between the 1990s and then, the couples match had doubled over that time. I'm sure it's continued to increase based on what we are seeing in recruitment.
Thank you, Cami. Any other questions, comments? If not, I really appreciate everyone's time, and I'm happy to end early and people can enjoy the rest of their lunch hour. But thanks everyone for your engagement and questions, and hopefully you have some takeaways from today. Thanks.